Okay, rapid BST board review. So we'll start with bone. I like to approach how to think about bone tumors, right, in terms of what's the age, because mostly we're dealing with sort of benign things in kids and malignant things in adults. Where in the body is it, the axial, the appendicular, and exactly where? Where in the bone is it, the epiphysis, the metaphysis, or the diaphysis? Because different things will occur in different places, and as we go through these things, we will kind of see key examples of what those are. And then, of course, benign versus malignant, right? We all know that if you are doing a frozen, the worst thing you can do is call something that is actually malignant benign, because then they'll curette and contaminate, and the patient is no longer eligible for limb-sparing surgery, right? So in real life, right, not necessarily for boards, but in real life, caution is always your friend. Okay, so we'll talk about histologically overlapping tumors, i.e. bone forming, and then cartilage forming, and then where they occur in, on, or around the bone. So we'll start with bone forming tumors. Most common primary bone tumor, right, is osteochondroma, but it is a cartilaginous neoplasm, right, as we will see. Most common primary bone malignancy in kids is osteosarcoma. Most common primary bone malignancy in adults isn't even osseous, right? It's hematopoietic, which is multiple myeloma, and then metastases, which is, of course, not primary, but you see it very, very often. Okay, so when boards like to test you on most common is common, these are its for bone. Okay, so most common primary bone tumor is a benign cartilaginous neoplasm, right, which is osteochondroma, which occurs only in endochondrally ossified bones. So if you think about bones that are intramembranously ossified, like your skull, we don't really see osteochondromas there. This induces bone induction below it, and the bone below it is continuous with the marrow in the normal bone, and patients with multiple hereditary exostosis are at risk for development of secondary chondrosarcoma, which is an outward, usually kind of cauliflower-like growth of that cartilage, rather than it invading inward. It usually kind of exophytes outward. And this is what it looks like. So this is why we always ask you to measure the cartilaginous cap when you're grossing it, because the bigger and bigger and bigger it gets, the more at risk for chondrosarc. Mostly these patients already have imaging that shows these voluptuous, like large lobules growing outward into the soft tissue. So that's chondrosarc. This is the classic cauliflower radiographic finding of marrow continuity in an osteochondroma. All right, BPOP, or Nora's lesion, or subungual exostosis, bizarre parosteal osteochondromatous proliferation, is similar in as much as it has some lobules of immature cartilage. It has some lobules of, or islands of immature woven bone. It has islands of fibrous tissue, but in an irregular arrangement, not nice and layered like the osteochondroma. It's usually on small bones, and it's often, as the name suggests, in the region of the finger bed subungual. So possibly not even neoplastic, possibly just reactive. It does not have marrow continuity below it. It just kind of sits on the surface of the bone and is this irregular haphazard proliferation. Enchondroma, right, intramedullary, hyaline cartilage, lobulated with peripheral ossification, but no central entrapment of lamellar bone, right? You can have woven bone or mineralization being deposited, but you should not have it entrap or invade or surround, right, pre-existing lamellar bony trabeculae. Otherwise, that's chondrosarc. These in the sort of proximal areas, like you see here in the humerus, they tend to be less cellular. In the distal digits, they tend to be more cellular and still benign. Listed on the left here are the syndromes in which enchondromas can occur. And outside of syndrome, they can have IDH1 or IDH2 mutation, which does not differentiate them, right, from intramedullary conventional chondrosarcoma, which can also have IDH1, IDH2 mutation. IDH mutations tell you that it's not, my words are failing me, it's too early in the morning. IDH tells you that it's not osteosarcoma, right, but it does not tell you whether it's benign or malignant cartilage. It just tells you that it is primarily a cartilaginous neoplasm. So what chondrosarcoma can be slightly more cellular, slightly more atypical, but must entrap pre-existing sort of normal trabecular bone, essentially in order to be called malignant when it's low grade. Obviously, if it becomes high grade, like more cellular, more atypical, or dedifferentiated, right, that's a different story. But when it's low grade, you want to see osseous entrapment. Usually these are unresponsive to chemoradiotherapy, so usually surgery is the call for chondrosarcs. Clear cell chondrosarc is a little bit different. It's specifically in the epiphysis of long bones of adults, right? So the growth plates are gone in the adults after, skeletal maturity. However, it exists in that area, right? So basically the distal caps of the bones. These have islands of conventional cartilage. However, the majority of cells are these clear cells that almost look like they could be epithelioid, but they're not, they're chondroid. And just like other chondrosarcs, this may dedifferentiate. These are pretty rare. Mesenchymal chondrosarc, similar in a way, in as much as it has mature islands of hyaline-ish cartilage or myxoid cartilage and interspersed areas not of clear cells, but of these immature primitive spindled mesenchymal cells, right? So cartilage and clear cells, cartilage and mesenchymal cells. Specific rearrangement here is Hay NCOA2, poor prognosis, generally in the sort of gnathic bones, jaws of teenage patients, rather than adults. Okay. Additional cartilaginous neoplasms include chondroblastoma. So this is most specifically in the epiphyseal region in children. So immature, right? True skeletal immaturity. These are giant cells plus mononuclear cells. And how we differentiate this from other giant cell-rich neoplasms is a couple things. The morphology of the background mononuclear cells, which are kind of these raisinoid, wrinkled, coffee bean or kidney-shaped nuclei in these very small cells in the background. We see these stippled kind of so-called chicken wire calcifications, right, that really nicely outline each of the individual cells. But each of the individual cells, if you're thinking, oh, this reminds me of, could this be osteosarc because of that bone? Well, the cells inside are super bland, right? If you're ever not sure, you can do the histone mutation. So this is the HK36M, right? So this, remember, the histone mutations are in chondroblastoma and giant cell tumor. The K36M is in chondroblastoma, and you'll see the other one, which is in giant cell tumor shortly. CMF or chondromyxoid fibroma, eccentrically placed, usually in kids, so kind of at the edge of the bone, near the cortex. Lobules of this sort of myxoid cartilage with peripheral hypercellularity. And in that hypercellularity, you often see giant cells. So this low power appearance is very characteristic. And when you look on higher power, you'll see this bland chondromyxoid stuff with these hypercellular areas. You can get sort of symplastic or degenerative or like ancient type atypia in these that is not regarded as malignant. These are associated with GRM1 gene rearrangements. Let me get my stuff out of the way. Okay, non-ossifying fibroma. Not really cartilage forming and not really bone forming, but kind of fibroblastic. So it looks like some people say almost a benign fibrous histiocytoma or a dermatofibroma in bone with these spindled storiform cells with these scattered admixed giant cells. It has this sort of soap bubble lobulated appearance. It is statistically, right, the most common cause of pathologic fracture in children. So when that comes up, most common thing, this is one of them. The other names for NOF are listed here on the left. These can be associated with syndromes, including NF1 or KRAS germline gene mutation, or sporadic KRAS or FGFR1 mutations, if you ever need to use that for diagnostics. So basically benign fibrous histiocytoma-ish of bone. Desmoplastic fibroma of bone is almost, I kind of like to think of as the desmoid tumor or the fibromatosis of bone. Again, young adult patients in various anatomic sites. Has these long fascicles of fibroblasts, myofibroblasts, just like fibromatosis. However, not all of them, but many of them have beta-catenin nuclear expression as well as occasional beta-catenin mutations. So I wouldn't rely on beta-catenin as much as I would in fibromatosis, but the morphology is quite similar. Okay, true giant cell tumor of bone, as we were sort of mentioning earlier. This can happen in an age range that spans from the sort of skeletally immature or verging on skeletal maturity to early skeletal maturity. So giant cell tumor bone can span that spectrum. It can be locally aggressive appearing on your radiographs, so don't use that necessarily as an indicator of malignancy in this tumor. It can extend outside of the bone in some instances, and even in occasional, in a benign morphology, metastasize to spots called lung, but really not spots such as lung, but not cause mortality. So we know that in GCT, the neoplastic cells are the background mononuclear cells. They have similar nuclei to those in the giant cells, which are oval, sort of moderate sized, and having small nucleoli. So that's how we can distinguish them from other giant cell rich tumors. Additionally, often the giant cells in the background are very pronounced and have tons of nuclei, 10, 20, 30, 40, 50 nuclei in some cases. Mutation here is G34W. So again, you can use that IHC if you need to. And when you treat these patients with denosumab, which is a rank ligand inhibitor, they mature. They lose the giant cells and they mature to bone, right? So because you lose that rank ligand signaling that's recruiting the giant cells, you lose the giant cells, you make bone. This can mimic something like a low-grade fibroblastic osteosarc or a fibrous dysplasia. So always be mindful, right? If you see this, think about history, think about treated giant cell tumor. Aneurysmal bone cyst, another giant cell rich tumor of bone. Remember your key buzzwords, right, which are fluid levels. Most of these osseous lesions, right, are occurring around the knee in teens, just like GCT bone, but that's a common anatomic site for osseous tumors. You can see here the fluid levels on MRI. Sorry, let me hide those controls. You can see fluid levels on MRI. And if you're lucky, right, you'll see these large cysts with blood-filled spaces. The walls of the cyst are composed of this kind of fibroblastic tissue, almost with a storiform arrangement, with giant cells, and then with giant cells jumping off into the like lemmings into the void, right? So this is cystic ABC. Remember, you can have no cysts, you can have solid ABC, but look for that similar structure in the wall. You can have osteoid, and you can have this so-called blue bone in which the bone kind of ossifies or calcifies, and you have this bluish appearance. USP6 is the driver. We also know, right, whenever I think about what drivers have in common, other tumors that are USP6, right, including ABC or nodular fasciitis, some cellular fibromas of tendon sheath, and there's one other one here that's missing, which is myositis ossificans. All right, we'll get to that later. Okay, come on. All right. Versus telangiectatic osteosarc can have cystic blood-filled spaces with fluid levels. However, when you look in the wall, it's malignant. We've got mitoses, we've got severe cytologic atypia. Sometimes osteoid is sparse, so look around for it. But when you have this appearance with malignancy and cystic spaces, think about telangiectatic osteosarc. Again, just like other osteosarcs, this is generally in long bones of like kids, teens. Last cystic lesion, unicameral bone cyst or simple bone cyst. Usually it's these very radiolucent, sometimes multiloculated lesions without fluid levels. And when they get in there and they try to scrape, there's like nothing. So you might get these thin strips. These thin strips have this almost kind of collagenous or osteoid-like material in the wall, which is very common. Sometimes you see a couple giant cells here and there, which might make you think about an ABC, but really the walls are super thin and often have this collagenous lining. Okay. Other giant cell rich lesions, we think about brown tumor of hyperparathyroidism, in which parathyroid hormone activates osteoblasts and osteoclasts. Right, so in the adjacent bone, you'll see a ton of bony resorption if you're lucky enough to have adjacent bone. But the growth pattern of a brown tumor with is very similar to that of a giant cell granuloma, sometimes in history called giant cell reparative granuloma. These names keep changing. I cannot promise you in what era, right? The boards will have their nomenclature, right? So you always want to remember what the sort of historic names for things were, because sometimes the boards have the historic names in the questions. So giant cell reparative granuloma, peripheral giant cell lesion, right? These are all words that were used for this. If this is in the context of a syndrome, i.e. cherubism, right, with where these kids have big puffy cheeks, it's bilateral jaw enlargement with this lesion, right, which is basically this growth of background mononuclear to sort of spindled cells with clustered osteoclast like giant cells, lots of extravasated red cells and hemosiderin. And this looks kind of exactly the same as brown tumor. So just check parathyroid hormones, check for syndrome, check that it's also not, what does it also mimic? Kind of a solid aneurysmal bone cyst, right? So those three things I would keep in mind. Okay, questions?
I have some, that's not really important. Is the mesenchymal chondrosarcoma syndrome associated ever?
Not that I'm aware of.
Okay. If you get a biopsy, or would you get a biopsy of like a suspected endochondroma versus chondrosarcoma, and in those cases, if it's really fragmented, do you just sign it out descriptively if you're not sure?
Yes. So if you get and you always use radiology, right? So if you get a fragmented enchondroma, you will say, and the surgeons will not like this, low-grade cartilaginous neoplasm, see comment. I do not see any osseous entrapment. Let's check radiology. If radiology thinks this is an enchondroma, cool, I can support that. If radiology thinks this is a low-grade chondrosarcoma, I could theoretically support it, but I don't see bony entrapment. If radiology is unsure, I can't help you.
Okay. Yeah. And then is there any treatment for like the cherubism, that syndrome?
That is an excellent question to which I do not know the answer. Like medical therapy, aside from like removing the lesions, I don't know. You can Google it and let us know. That'll be our homework for today. Okay, moving into bone. So osteoma, solid, radiodense, thick lamellar bone. If multiple, think about Gardner syndrome. Otherwise, not too much to say about osteoma. They can occur in craniofacial bones and other. Osteoid osteoma, classic clinical syndrome of young adult, night pain, relieved with NSAIDs like ibuprofen. There is in the cortex of the long bone, in the cortex, right, there is a radiolucency with a central nidus. That is osteoid osteoma. The central nidus is thicker bone. The radiolucency is this osteoid with a vascularized connective tissue. Usually you will see osteoblast rimming, right? So osteoblast rimming usually means benign. You generally won't see osteoblast rimming in neoplastic bone of osteosarc, but you may see it in reactive conditions or benign neoplasms such as this. FOS-FOSB rearrangement is what the driver of this is. Similarly, osteoblastoma, also FOS-FOSB rearrangement, but not really that night pain, not really cured by NSAIDs, right? So it's a little bit of a different clinical scenario, generally tends to be larger, and the osteoblasts in osteoblastoma can be quite plump compared to those in osteoid osteoma. Truly in osteoid osteoma, usually they radiofrequency ablate these and you won't see, I could swear here, but I won't, you won't see anything. In osteoblastoma, they don't usually radiofrequency ablate these. They biopsy them to make sure they have the right diagnosis. So you will see these plump osteoblasts. If you want, you could do FOS-FOSB IHC. Okay, osteofibrous dysplasia, also characteristically, right? So when there is an anatomic site that is really specific, we want to memorize it. So anterior tibial cortex, usually a young male. That is one of two things. That's this, which is osteofibrous dysplasia. So it's kind of like ossifying fibroma of mandible. You have variably cellular stroma, variably sort of shaped woven bone with osteoblast rimming. What it can do is progress to adamantinoma. The thing we want to worry about with adamantinoma is what can it do? It can metastasize. What is adamantinoma? It's basically either osteofibrous dysplasia looking tissue with epithelial islands, right? So you throw a keratin and these light up. So when you see an OFD, throw a keratin on it, make sure you don't have ameloblastic islands or adamantinomatous islands, right? The classic adamantinoma looks like ameloblastoma, right? So osteofibrous dysplasia ossifying fibroma, adamantinoma, ameloblastoma. All right. Fibrous dysplasia, also a fibro-osseous lesion, but does not have osteoblast rimming, right? Tends to have these Sharpay fibers that imply that the bone is kind of ossifying right out of the stroma without being like deposited by osteoblasts, which is kind of interesting. Very monotonously cellular fibrous background, monotonous long strips of bone. Ground glass opacity is your buzzword for radiology. And then GNAS1 mutations in some cases. Syndromes are listed here, right? Polyostotic fibrous dysplasias with other things. Okay, this is very similar to primary intramedullary fibroblastic osteosarcoma, which is sometimes called low-grade central osteosarc. Again, most osteosarcs happen in the same age range, you know, teens-ish, teens to 20s, around the knee. And what you will see is slightly more atypical fibrous stroma in the background. These sort of long bones without osteoblast rimming and probably without Sharpay fibers, but MDM2 CDK4 amplification is critical. So many low-grade fibroblastic osteosarcomas have MDM2 CDK4 amplification. The other low-grade fibroblastic osteosarcoma we'll see momentarily is parosteal. All right, but first we will see conventional osteosarc, which is intramedullary, again, around the knee, in teens, 20s. Second peak in the elderly, or I guess maybe, you know, 50s, not really elderly, but like 70s, 80s, with Paget's disease, right? Or other sort of secondary bony infarcts, right? So teens, old people, conventional osteosarc. Usually it's high grade. You want to look for osteoid. Sometimes it gets very finely calcified, and you look for malignant cells entrapped within the osteoid. We don't use SATB2, right? We think about SATB2. I know now it's used for like colon cancer and such, but originally it was described as osteoblastic. Yes, but it will stain benign bone and malignant bone, so we don't use it. Oh, the other thing I was going to say about osteosarc is the osteosarcomas of the jaws are in the middle. So you have the teens and the elderly, and the osteosarcomas of jaws are kind of in the middle, like 30s, 40s, and tend to be chondroblastic rather than osteoblastic, and tend to not respond to neoadjuvant chemo radiotherapy, which is why they are primarily resected versus these, which are treated with neoadjuvant chemo. What's the percent response you're looking for after neoadjuvant chemo to show that it is a good responder?
90%.
90%. Okay. This is Codman's triangle, which is the elevation of the periosteum due to peripheral infiltration by bone, right? That lifts the periosteum up off the surface. And you can see that radiographically. So that's classic imaging finding of conventional osteosarc. All right, this is what I was talking about earlier, those surface osteosarcomas that, again, usually occur in the around the distal femur of young patients, and are either so-called parosteal or periosteal. I can never remember this. I have to like say the words 5 times over. Parosteal is the one that is fibroblastic and MDM2 amplified and low grade and usually treated with primary surgery. Periosteal is the one that is more chondroblastic, can be of low to intermediate grade, and if it's on the intermediate grade spectrum, they may treat with neoadjuvant chemo. The bone in periosteal can be very sparse, especially if it's only a biopsy. But if you have this radiographic appearance, right, this sort of sessile fusiform expansion around the distal femur, think about these surface osteosarcs. So this is parosteal, this is periosteal. We move on. You already know about Langerhans histiocytosis, but you see this on the heme service and you see this on the BST service, right? Because we're getting these biopsied normally in kids. You've got these mononuclear histiocytes with coffee bean and wrinkled and racinoid nuclei with your background EOs. Yeah, we don't do EM anymore, but the tennis racket shaped Birkbeck granules. We think about CD1A, Langerhans, S100, and BRAF V600E. They can be single, they can be multiple. Ewing sarcomas, right? Small round blue cell tumor can be in bone mostly, can also occasionally occur in soft tissue, can occur in young, can occur in old, kind of everywhere. Sometimes has rosettes, sometimes doesn't, right? But when you think about monotonous small round blue cell tumor, always want to exclude Ewing's. CD99, diffuse strong positive, FLI1 or ERG can be nuclear positive depending on whether your partner is FLI1 or ERG. Joints, not that kind. So just very, very quickly with joints, we think about gout versus pseudo-gout, right? Gout, do we have questions on bone before I move into joints? Okay. Gout, pale in color on low power, usually surrounded by a giant cell reaction and needle-shaped. If you do not process these in alcohol, you may wash out the crystals, so you may just see the holes left by the crystals. If you polarize them and you get lucky, you may see these shards. Pseudo-gout usually looks purple on low power. Rhomboid-shaped crystals, usually no to minimal giant cell reaction around it. Does not require special processing. Tenosynovial giant cell tumors are either of localized type or diffuse type. I don't know whether the boards are going to be up to date on the terminology, but the localized type used to be called GCT of tendon sheath and the diffuse type used to be called PVNS. They're both the same. They both have a combination of mononuclear histiocytes, foamy histiocytes, and giant cells, and hemosiderin. And now we know CSF1 gene rearrangements. The one on the left, right, as you might suggest, is a single nodule, right, usually stuck to a small joint. PVNS is sort of this carpeting villus problem that is in a larger joint, like a knee. Yes, you can get a single localized type on the knee, but if you're going to see a diffuse type, it's probably more likely going to be in a larger joint. Okay, then you have synovial chondromatosis, which is looks kind of like osteocartilaginous loose bodies that you can see in like osteoarthritis, but is always lined. All of these things are lined by synovium, and they sort of are very diffusely involving the knees and the subsynovial tissues. If you are not sure whether this is degenerative or neoplastic, you can do FN1 gene rearrangement because these are FN1 associated. All right, soft tissue. Excellent. We may go over 9, but I'll try to get through this quickly. All right, fat. So remember, what is the morphology of fat? This is going to be critical for all your fatty tumors, right? Normal fat cell is round. It has a kind of a bulbous, fusiform shaped nucleus. Brown fat has a nucleus in the middle with vacuoles around it that are not compressed by the vacuoles. Lipoblasts, right, have nuclei that are either peripheral or central and compressed by the vacuoles. Fat necrosis can sort of sometimes mimic atypical lipomatous tumors, but because they have this reduplication of the cytoplasmic membrane when the cells die and they have histiocytes coming in, right? But remember, if you see histiocytes and this reduplication, this is fat necrosis, not neoplastic. Okay, chart of benign adipocytic tumors. All of them have specific gene loci that are implicated. The one that we mostly actually use diagnostically, genetically, is spinocellular pleomorphic lipoma, right? So this is characteristically sort of older men, posterior neck, shoulder, back. But remember, it can occur in other anatomic sites as well. It usually has ropey collagen. It usually has these blunt, sort of cigar-shaped spindle cells that often sort of collect together in a palisading arrangement. It can have hyperchromatic or floret cells, in which case it would be more on the spectrum of pleomorphic lipoma. But what these have are, the books say CD34 positivity, but I think CD34 is positive in a lot of fibrocytes. So to me, it's kind of useless, but for your board's review, it's there. And loss of retinoblastoma. So if you do the RB stain, these nuclei will be negative. If you're differential, it's atypical lipomatous tumor, MDM2 CDK4 negative. Other tumors that we might want to think about include something like hibernoma, right, which is any proportion of brown fat, angiolipoma, which tends to be multiple, painful, forearm, familial, right, and have capillary-like vessels with fibrin thrombi. And then lipoblastoma, generally a neonatal problem, generally has these chondroid or myxoid islands. If it's lasting into the child's sort of toddlerish age, right, it can mature to look almost like a mature lipoma. But if it's been present since birth, think about lipoblastoma. These have plaque translocations, just like what? Pleomorphic adenoma of salivary glands. All right, when we think about the non-benign adipocytic tumors, spindle cell and pleomorphic lipoma are on a spectrum, with so-called atypical spindle cell pleomorphic lipomatous tumor, which you take the base, right, and you give it increasing cellularity or nuclear atypia and mitoses. Why do we care? Because this has a propensity to locally recur with as much frequency as ALT, right, / well-diff liposarc, which we know can start on that base, right, and then progress to D-diff liposarc. Similarly, myxoid liposarc can progress to round cell liposarc, and finally, pleomorphic has no low-grade counterpart. They are all aligned, right, by what? Their genetics. So retinoblastoma loss in these, 12q gain, which is MDM2 CDK4 amplification in these, FUS-DDIT3 fusion in these, and complex nonspecific karyotype here. Remember, we call ALTs in the trunk and extremities, and we call well-diff liposarcs in the retroperitoneum because these can escape detection and dedifferentiate much more than those on the trunks, which are removed and watched and removed and watched. Okay, morphologically, right, we've got usually adipocytic morphology with atypical hyperchromatic cells in ALT with high-grade spindle cell neoplasm in D-diff. Myxoid, right, has your curvilinear blood vessels with myxoid stroma and lipoblasts, and then progresses to potentially round cell with these sort of small clustered cells, and pleomorphic liposarc, just pleomorphic lipoblasts. So genetics, right, are going to be MDM2, DDIT3 FUS, nonspecific. You, in the retroperitoneum, right, if you see something that looks like pleomorphic liposarc or something that looks like myxoid liposarc in the retroperitoneum, it is either, right, the myxoid variant of well-diff or the pleomorphic variant of D-diff. It is always an MDM2 problem in the retroperitoneum, okay? So the morphology can vary, but the genetics in the retroperitoneum are always MDM2, unless it's a metastasis from one of these other tumors outside from the trunk and extremities that metastasizes into the retroperitoneum, okay? Just always keep that in mind. If you want a chart of comparison, here it is. Usually myxoid, you're dealing with younger patients, right? ALT, D-diff, you're dealing with adults, and pleomorphic, you're dealing with older adults. We don't look for lipoblast in a typical lipomatous tumor. We do look for them in myxoid / round cell, and we do look for pleomorphic ones in pleomorphic. Round cell, thing I need you to remember, right, is 5% is thought to be the cutoff for portending poor prognosis. So we try to kind of estimate what percent round cell. Questions? These are just here for you. The most fatty tumors you're going to see in real life, the most soft tissue tumors you're going to see in real life are fatty. So we spent a little bit more time on those. Okay. Moving into myogenic, smooth skeletal and perivascular myoid. Leiomyosarc. I'm not talking about uterine ones, right? That is a whole different ballgame. Those have different criteria. If you're in the soft tissue, skin, and you have any amount of hypercellularity, cytologic atypia, mitotic activity, there's no such thing as a stump, right? These are leiomyosarcomas. In the retroperitoneum, these usually come off of large vessels like the inferior vena cava. They go outward, right, off the vessel rather than inward. If you have a spindle cell neoplasm that's in the lumen of a vessel, of a large vessel, I don't think I have this in here, but you might want to think about something like an intimal sarcoma. Okay, you can't have aberrant expression of keratin. You can't have aberrant expression of ER and PR in retroperitoneal smooth muscle tumors in men and women, so it does not tell you whether it's a GYN-associated thing. And then when you have an immunocompromised patient, think about doing an Epstein-Barr virus, EBER, because these have better prognosis. Okay, skeletal muscle, rhabdomyoma. We have cardiac rhabdomyoma with glycogenated spider cells. We have adult head and neck rhabdomyoma, often in sites like tongue, with these large eosinophilic striated cells. We have fetal and genital rhabdomyoma with strap cells. Clinically, we're either dealing with sort of post-auricular region of kids or genital region of adults. But all of them have this primitive myotubules. These are super rare. Rhabdomyosarcoma, not so rare. We generally think about embryonal, right, in kids. If you have these sort of grape-like structures, right, that are protruding from epithelial-lined organs like the mouth, the vagina, the bladder, right, this is called botryoid. It tends to have this cambium layer, right, which is accentuation of hypercellularity right underneath the epithelium. Otherwise, you have these alternating zones of dark and light. If you look carefully, you may see rhabdomyoblasts with cross-striation or these rhabdoid cells with eccentric eosinophilic cytoplasm. Remember, nuclear markers of skeletal muscle differentiation are myogen and myod1. You should always usually also have Desmond, right? So Desmond can be a screener for rhabdo. You don't have to necessarily jump to the nuclear markers. If you have diffuse strong myogenin expression, this is probably a fusion-associated tumor, i.e. alveolar. So the morphology of alveolar and embryonal can overlap, so we always want to do the myogenin to see how diffuse it is and or the genetics. It's a kid, so most institutions are going to go for the genetics. Alveolar is PAX3 FOXO1 or PAX7 FOXO1. It doesn't always have to have the alveolations like the nested growth, but it can be sort of large, plump, and almost well, definitely rhabdoid looking with prominent nucleoli. And if it has the fusion, it's going to behave more aggressively. Pleomorphic rhabdo, now we're dealing more with an adult situation, right, with the embryonal and the alveolar. Mostly we were dealing with kids. Pleomorphic now is in adults. So this has large pleomorphic rhabdoid-looking cells with nuclear markers of rhabdo differentiation. Can show nuclear MDM2, but without true amplification. So your differential might be a D. diffliposarc with heterologous rhabdomyoblastic differentiation. But if you do the MDM2 fish and it's not amplified, then you're dealing with pleomorphic rhabdo. Regardless, it's poor prognosis, high-grade sarcoma. Then there's the spindle cell rhabdo, which is kind of a variable, heterogeneous entity. So it could almost look like a myofibroblastic or a smooth muscle neoplasm. Occasionally, you might see cross-striations in rhabdoid cells, and occasionally you'll have extensive collagenous deposition, which is called the sclerosing variant. This can happen in kids in the paratesticular area, adults in the deep soft tissue of head and neck. Depending on where you are and what age you are at, you might see different genetics. So is this one entity? Is this many entities? I don't know, but it's all listed under spindle cell rhabdo. These intraosseous spindle cell rhabdos of the head and neck, interestingly, have TFCP2 fusion. So now this is a new specific entity of TFCP2 rearranged rhabdo. If it has the myod1 mutation in adults, it's thought to have worse prognosis. All right. In terms of comparative charts, if you are looking at a small round blue cell tumor like an embryonal, right, or an alveolar rhabdo, which on your differential, especially in a kid, right, might be something like Ewing's, your third differential, especially if you're in the intra-abdominal compartment of a teenage person, might be a desmoplastic small round cell tumor. So islands, right, islands of small round blue cells surrounded by this extensive desmoplastic stroma and having multi-phenotypic differentiation. So epithelial, yes. Myogenic, yes. Neural, yes. Cytoplasmic CD99, maybe. It specifically has WT1 as a fusion partner, right, rather than Fly1 or ERG. So you may see WT1 expression. If you are in an adult, right, and you see a small round blue cell tumor, you are certainly also going to think about things like carcinoma, melanoma, lymphoma, right? I'm not even putting on there your things like small cell osteosarc, round cell liposarc, right? But these are all things that can come up in the differential. As well as the Ewing's like sarcomas, which depending on whether you're in soft tissue or bone, you're either dealing with bone, usually which is the B core tumors, soft tissue, usually the chick ducts tumors or sick ducts. I don't know how people like to call this. These are usually a clue because while they are small round blue cell, they have a little more architectural heterogeneity. They can have myxoid background. They can have these little microcysts. They may have more cytoplasm. And when you throw CD99 on there, it's usually not strong and diffuse. It's usually kind of patchier and weaker. And you can either stain or probe for the B core or the chick by IHC or by FISH or NGS. Okay, usually these are kind of treated in the Ewing's, just like desmoplastic small round cell. These are kind of treated like Ewing's. All right, perivascular myeloid tumors. On the left, we have the very primitive glomus tumor, distal extremities, painful, blue bumps, right, with uniform fried egg cytoplasm and positive for your myogenic markers, syndromically associated with neurofibromatosis 1 or GLM and glomalin gene in familial cases. And then all the way on the right, we have your very, very well differentiated spindle cell smooth muscle tumor, angioleiomyoma. Again, usually extremities, usually painful, very circumscribed, but you have these smooth muscle bundles that kind of like emanate and whirl off of the vascular lumina, right? So you have this whirling and this smooth muscle in the background. Usually, again, myogenic marker positive. In the middle, where you have these kind of myofibromas, myoparasitomas, which are a little bit kind of hybrids. Sometimes they have plump kind of glomoid spindles, glomoid epithelioid cells. Sometimes they have mature smooth muscle cells. Sometimes they have this kind of in-between myxoid stroma. Sometimes they are within or kind of undermining vasculature or have prominent vasculature in the background. So I kind of like to think of these as like a kind of a hybrid of the spectra. You can have multiple in myofibromatosis. Okay. All right, true vascular tumors, right? So these were tumors of pericytic or perivascular cell differentiation, right? So they have the contractile markers. These are muscles of true muscles. These are tumors of true endothelium, right? So you have the benign, you have the malignant, and you have the intermediate or indeterminate malignant potential. Starting with the benign, infantile hemangioma, right? Kids, grows rapidly, might regress. Depending on what phase you're in, you might see plumper or flatter, but you should always have GLUT1 positive in the membrane. Remember, GLUT1 is also on red blood cells, so you might see that in the lumen. Epithelioid hemangioma or angiolymphoid hyperplasia with eosinophilia, vasoformative, very plump endothelial cells, often with EOs and such in the background, and usually should have nice pericytic layer around the edges with, your Fly1, your ERG, your CD31, your CD34 in the actual neoplastic cells. Correct me if I'm wrong, but aren't these also FOSB? Can you double check? I don't want to say something wrong, but I didn't have it in the presentation, so I didn't want to miss
They
it.
are.
Thank you. All right, so add in your brain, FOSB. Okay. Versus epithelioid hemangioendothelioma, which is non-vasoformative, right? This almost looks like single cells or single file cells in a collagenous to myxoid to sort of chondroid stroma. These are the only evidence that they're vasoformative is these little blister cells, some of which have red blood cells in the lumina. Like many epithelioid smooth muscle, why do I keep saying the wrong things? Like many epithelioid soft tissue tumors, these can have keratin, right? So when you think about what mesenchymal tumors can express keratin, it's usually those that are epithelioid, that have some kind of mesenchymal to epithelioid transition, such as this. They should retain your markers of endothelial differentiation. WWTR Campta1 is the most common fusion. They can be multifocal, they can be metastatic, and have some prognostic indicators here. Pseudomyogenic hemangioendothelioma is spindle cell, has hybrid sort of epithelial, myogenic, and endothelial differentiation. Genetics, Serpine, FOSB. When you're thinking about which vascular tumor is it, right? Remember that usually the hemangioendotheliomas, at least epithelioid, is not vasoformative. And true angiosarcomas often do have some vasoformation, even if it's primitive and poorly formed, right? Epithelioid, I don't know why epithelioid sarcoma is in here, but it may mimic an epithelioid hemangioendothelioma, but immunoprofile is different. We'll get to epithelioid sarcoma later. Okay, types of angiosarc, right? We have the primary cutaneous, sun-exposed scalp of older patients, highly infiltrative, no specific molecular aside from ultraviolet signature. Deep, soft tissue angiosarc, usually solid or vasoformative and high-grade and epithelioid. Primary breast angiosarc, deep in the breast, young women, very bland. Radiation-related angiosarc, right, or lymphedema-related angiosarc is usually in the skin of patients who've had breast cancer and are associated with MYC amplification, right? So MYC, bless you, should not be present in the non-post-radiation, non-post lymphedema syndromes. Okay. Kaposi's sarcoma, okay, for Dr. Kraus. 4 variants. The classic sort of indolent elderly Mediterranean man version, the endemic African version in patients who are not immunosuppressed, the iatrogenic, where we have immunosuppressed the patient because we've given them an organ transplant, and then the AIDS HIV associated, which is the most aggressive form. So all morphologically similar: spindle cells, extravasated red cells, hyaline globules, HHV8 IHC. All right, nerve sheath tumors. Remember nerve sheath, gosh, sorry, this is going to be longer than an hour. I'm sorry. So we've got perineural cells, we've got Schwann cells, we've got all of the supporting cells in between, like the fibroblasts, right? So when you're dealing with each of those cell types, you get different tumors. So Schwann cells only, of course, schwannoma, S100 diffusely positive. You can have variants, conventional, ancient, right, with smudgy atypia, cellular, which has no varicate bodies, plexiform, which is multinodular and has an association with NF2, microcystic reticular schwannoma in GI tract, multiple schwannomas associated with neurofibromatosis 2, right? So bilateral acoustic neuromas are what? Bilateral vestibular nerve schwannomas, schwannomatosis, which is SMARCB1. Usually these do not have a risk for malignant transformation, usually, right? Unlike neurofibromas, which do. Different beast is malignant melanotic Schwannian tumor, formerly known as Pseumomatous melanotic schwannoma. This is paraspinal. This has hybrid Schwannian and melanocytic differentiation, so it kind of stains like a melanoma, right? But it is not a melanoma. It is this tumor. It can be associated with Carney complex. It does not have any of the melanocytic melanoma genetics, and these patients do not have any cutaneous melanomas. These are deep primary mesenchymal tumors. Plexiform neurofibroma, right, is your pathognomonic tumor for neurofibromatosis 1. You get these diffuse sort of, shreddedy, carroty spindle cell proliferations in the background, and then these bags, right? You can see these lobulated bags. That's plexiform. Perineurioma, very whorled, tightly packed storiform, has markers of perineurial differentiation like EMA, CD34, GLUT1, Claudin-1, no S100 SOX10, right? Because these are not Schwannian. These are perineurial. Hybrid schwannoma perineurioma has hybrid combined EMA and S100 in different areas of the tumor, and specifically VGLL3 fusions. MPNST can arise, right, from a plexiform neurofibroma in an NF1 patient or be sporadic de novo, usually arising on or from a nerve. The problem is these don't often have S100 or SOX10, so you're relying on the morphology with this marbling appearance or the epithelioid appearance, or if you're lucky and you get skeletal muscle differentiation in an MPNST, you get a Triton tumor. You are relying on the fact that this is either in a syndrome or is associated on, with, or near a nerve clinically. Okay. And last bucket of fibroblastic, myofibroblastic tumors. We go. Nodular fasciitis. Sometimes there's trauma. Usually there's rapid growth. Usually it's smaller than 5 centimeters. It can be circumscribed or infiltrative. It tends to have these 4 areas. You get this young cellular plump fibroblasts. You get these spindled sort of stellate fibroblasts. you get keloid-like collagen and extravasated red cells, and you get these microcystic myxoid stromal changes. Think about nodular fasciitis. If you're curious, right, sometimes they have smooth muscle axon because they're myofibroblasts, but mostly they have USP6 gene rearrangement. Remember, what else has USP6? Aneurysmal bone cyst, fibroma of tendon sheath, myositis ossificans. Okay. Other fasciitides include the intravascular fasciitis, the cranial fasciitis, the proliferative fasciitis, which characteristically has these ganglion-like giant cells, and then the ischemic fasciitis, which is specifically in immobilized ischemic zones of elderly patients. Don't worry, I'll give you this presentation so you can peruse all of this stuff later. All right, fibromatoses, most common, desmoid. Usually abdominal wall of a sort of reproductive age female, but not specifically here. This is just the most common setting. Can be associated with Gardner's, long, pale, fibroblastic, myofibroblastic fascicles with elongated nuclei, with small nucleoli. You're looking for SMA, sort of tram track on the membrane, and you're looking for beta-catenin in the nucleus. Highly infiltrative, highly locally recurrent. Sometimes they medically treat these patients because surgery, sometimes they just keep recurring. When you're thinking about the fibromatoses, right, just like the fibromas, they all have a subtype. So you're not just going to call something a fibromatosis. It's either going to be deep, desmoid. It's going to be superficial, like the palmar and the plantar, like in Dupuytren's contracture. Remember that the plantar fibromatoses can have these giant cells in them because they are sort of aggravated by walking, and not as frequently related to beta-catenin mutations. Fibromatosis coli or torticollis, usually you don't see this. These patients are treated with physical therapy. Juvenile hyaline fibromatosis is this very rare autosomal recessive disease of this sort of hyalinizing material in various parts of the body that are sort of PAS positive. There's the gene that's associated. Inclusion body or infantile digital fibromatosis has these little inclusions next to the nucleus that stain red on trichrome. Lipofibromatosis, quite rare. You can see this in the distal extremities of young patients with fat and this spindle sort of fibroblastic tissue unrelated to beta-catenin. Fibromas are either fibroma of tendon sheath, right? Distal digits of adults, sometimes USP6. Nuchal type fibroma, right, in diabetics with these very, very thick collagen bundles. Gardner fibroma entraps adjacent structures like nerve or skin adnexa, and throw your beta-catenin on there and screen for FAP. Elastofibroma, specifically between the scapula and the chest wall on your back, so kind of under the scapula, with these large elastic fibers, and sometimes they show beading if you do an elastin stain. Calcifying aponeurotic fibroma, distal digits and hands of kids with this sort of central calcified material and these peripheral histiocyte and fibroblasts. Okay, moving into the sarcomas. So hypocellular myxoid sarcomas. Word salad, right? Low-grade fibromyxoid sarcoma, i.e. LGFMS, versus myxofibrosarcoma. We're dealing with something that is by definition low-grade versus something that can be of any histologic grade but is usually high. Something that is in young adults on the extremities and trunk versus something that tends to be in older patients. Something that is generally circumscribed with discrete myxoid collagenous zones versus highly infiltrative with prominent myxoid stroma with curvilinear blood vessels and significant atypia in the background cells versus LGFMS, minimal nuclear atypia. Not all of them have collagenous rosettes. Even though this used to be called hyalinizing spindle cell tumor with giant rosettes, only very few of them have those rosettes. They do have EMA and or MUC4 expression, and FusCreb3L2 is the most common gene fusion. However, you can have late metastases in LGFMS, so these patients are monitored long-term. Myxofibrosarcoma, generally treated with resection and or neoadjuvant chemo if it's high grade, and they recur. Here's a comparison, right, between LGFMS and myxofibrosarc on the left and on the right, showing the cellular features and the atypia on the right. LGFMS, its high-grade counterpart is SEF, sclerosing epithelioid fibrosarc, which, as its name suggests, has plump epithelioid cells has collagenous stroma in the background, and can look like lobular breast carcinoma because it has these single file cells in this collagenous stroma, can look like osteosarcoma because it has this collagenous material in the background that resembles osteoid, and can be present in bone, can be present in soft tissue, can be present with an associated LGFMS, in which case it retains the same fusion, or can be present pure or de novo, in which case it has slightly different fusion with EWSR instead of FUS as partner. These can metastasize at higher rates than the low-grade counterpart. All right, synovial sarc, cellular, spindled, monophasic, or spindled and epithelioid biphasic. Usually young adults, often in a periarticular or juxtaarticular arrangement, which is why it used to be called, why synovial it was called, and it retains synovial but has nothing to do with synovium. It is one of the tumors, right, that has your so-called HPC or hemangioparasitoma-like vessels. I don't know if that word is still being actively used because we don't use hemangioparasitoma as a diagnostic entity anymore, but the vessels remain. They are thin-walled, they are dilated, and they are branching, right? So sometimes they're called staghorn. Monophasic has SYT-SSX2 fusion, biphasic has SYT-SSX1. You can get high-grade or poorly diffed synovial sarc with increasing amounts of round cells and atypia. Generally, all of these will stain with an EMA and or keratin. So if you don't see EMA or keratin, rethink your diagnosis. TLE1 is non-specific, so we start to use the synovial sarc-specific IHC. Okay. SFT can be anywhere. This is what used to be called HPC, right? But now we know it as the STAT6 rearranged tumor that occurs, off the pleura, that occurs in the deep soft tissue, that occurs in the head and neck and the sinuses, right? That occurs in the meninges. These are all STAT6 fused tumors, ranging from more collagenous to more cellular, to thin-walled dilated branching vessels, CD34 STAT6. Sometimes if they secrete IGF-2, hypoglycemia. The boards loves this association. Behavior is not always predicted by histology, but we have this risk stratification that includes size, margins, cellularity, mitoses, etc. These should all generally be regarded as potentially malignant, and you grade them on the risk stratification profile. IMT, kind of a diagnosis of exclusion. If you're lucky, they'll have ALK rearrangement. If you're not, they won't. Spindle cell fibroblast, myofibroblasts with abundant inflammatory cells in the background. Sometimes these ganglion-like cells. If you're unlucky, it's very scar-like and collagenous. Potentially the fusion-negative tumors in adults are thought to be worse. We'll see if that is true. Fibrosarc. Infantile fibrosarcoma, very specific. Neonates, herringbone, long fascicles, ETV6 NTRK3 fusion, good prognosis. Other fibrosarcomas in adults, there isn't a quote-unquote adult-type fibrosarcoma, which does not have any specifics genetically or morphologically, but is very rare. Most fibrosarcomas of adults are those that transform from DFSP, right? That, again, have this long herringbone fascicles, highly mitotically active, and they maintain the collagen PDGFB fusion of DFSP. These can metastasize, unlike DFSP, which really doesn't. All right, what other tumors have ETV6 NTRK? Secretory carcinoma, some thyroid carcinomas, some variants of mesoblastic nephroma, some leukemias. Okay. Undifferentiated sarcoma, again, a diagnosis of exclusion, but probably the most common sarcoma, including, along with, I should say, myxofibrosarc that you're going to see in adults. So no specific genetics, no specific IHC. It should be negative for essentially everything you throw on it, except for maybe some SMA and or Vimentin, right, which we don't really use for this. Can be pleomorphic, can be giant cell rich, can be spindled and round. Okay, we're going to not do the charts. Epithelioid sarc, we're getting there. Two types, distal and proximal, right? Distal, usually younger adults, kind of these subcutaneous nodules that almost look like they could be, I don't know, granulomas, but you're like, oh shoot, those aren't histiocytes. They're keratin positive and they're ion I1 lost. That's epithelioid sarc. Much more obvious, right, is the proximal type, which is highly epithelioid, often with rhabdoid appearing cells. Same immunoprofile, keratin positive, ion I1 loss. If you don't have ion I1, do the BRG, right? Because if it's not I&I, it's BRG. They can metastasize, and especially to lymph nodes. When you're looking at something on the distal digits that has this granuloma-like appearance, and you want to think about epithelioid sarc, distal type, right, throw your keratin. Otherwise, you might be dealing with something like a rheumatoid nodule, a granuloma annulare, or a calcifying aponeurotic fibroma if it's a kid, right? But these all have that similar kind of central core of fibrosis, necrosis, or collagen, and then this peripheral, either fibrohistiocytic or neoplastic periphery. Rhabdoid tumors. So I'm putting this next door because these are also keratin positive and I1 lost, right? So kind of depending on the location, right? You have epithelioid sarcoma in the trunk or distal extremities of adults. You have malignant extrarenal rhabdoid tumor in the paraspinal region of kids. You have renal rhabdoid tumor in the kidney of kids. And you have atypical teratoid rhabdoid tumor in the CNS, usually of kids. They all have an epithelioid component, right? Usually with rhabdoid cytomorphology, with keratin expression, and with I&I loss. All of them. They just kind of differ depending on where they're located and what age they're in. They have a bad prognosis everywhere. Some of the extrarenal rhabdoid tumors have familial association, like we saw earlier with the SMARCB1 syndrome. Okay. All of your chromatin remodeling complex tumors are now blossoming. Again, if it's not I&I1, it's BRG1, so we always do the two stains together. Some are more frequently I&I1 or SMARCB1 than others, and others are more frequently BRG1 or SMARCA4, like the thoracic sarcomas, your ovarian hypercalcemic small cell carcinomas, and some of your uterine sarcomas tend to be more SMARCA4. These are all chromatin complex remodeling. They all generally have point mutation in one copy of the gene and loss of the other. So you have basically loss of heterozygosity. You have elimination of both copies by mutation and just deletion. Okay. Questions? Sorry, I'm going over. Go for it.
Going back to the synovial chondromatosis,
yes.
Is there an age distribution associated with that, or can it be kind of seen?
I believe it's usually young, but you can double check me.
Okay.
Mm-hmm.
For the spindle cell rhabdomyosarcoma, do
yeah.
the fusions define the entity? Like, do they have to have the fusions?
They don't have to have the fusions, but if you have the fusion, it's a spindle cell rhabdo.
Okay.
Yeah.
And then the Ewing-like sarcomas, are those usually seen in kids?
Those can be in a wider range. Yeah.
The low-grade fibromyxoid sarcoma, does the fused Krebs fusion define it? Like, does it?
Generally, yes.
Generally? Okay.
Yeah. Very few are thought to not have it, but I don't know whether that's just inability to detect it or actual absence of the fusion.
Okay.
Yeah.
And do we have the SF-specific IHC stain here for synovial?
We do not. Mayo. Mayo has it. Okay, other questions? All right, alveolar soft parts. Oh gosh, when I do this on Saturday, I'm gonna have to speed it up. Okay. I don't know if I can go any faster, but I can. All right, alveolar soft part sarcoma. Usually younger patients. Nested, very pink, very epithelioid, prominent nucleoli, rhomboid crystals in the cytoplasm, stained with PAS, TFE3 rearrangement, so nuclear TFE3, otherwise no specific immunometastases are common. Clear cell sarcoma, formerly known as malignant melanoma of soft parts, usually distal extremities. You can also see this in the guts, right? These have melanoma-like looking globules of cells. They stain with HMB45, melanate, etc., but it's usually stronger than S100, so that could be a clue. You have no overlying melanoma in situ. You have no melanoma genetics. What you do have are EWSR ATF1. What other, I'm not giving you the head and neck review, but what other EWSR ATF1 clear cell neoplasms do we have, especially in the head and neck?
Hyalinizing clear cell carcinoma.
Ding, ding, ding. Hyalinizing clear cell carcinoma of salivary gland. And what else? What about its intraosseous counterpart? Adenogenic clear cell carcinoma, which is identical. Okay, great. Sorry, I like to make these connections. Like right when you see one fusion, like think about the other tumors that have the same fusion. I don't know if that's just me, but I do it in my head anyway, so we're going to do it together. Okay, PEComa, perivascular epithelioid cell. Mixed melanocytic myogenic differentiation. Usually you're going to see this in the GYN or GI regions. Again, it has a sort of rhabdoid appearance. Sometimes it can be clear cell. It has mixed myogenic and melanocytic differentiation, as I said. Okay. Epithelioid tumors with myxoid stroma. Now this is a specific differential diagnostic category, of which there are mainly three. We're dealing with soft tissue myoepithelial tumors, either benign myoepitheliomas or myoepithelial carcinomas, which are defined, right, by the presence of nucleoli, nuclear pleomorphism, mitoses, necrosis, rather than invasion, because these can be circumscribed and still behave malignantly. What do you need to show in a myoepithelial tumor? You need to show, one, an epithelial marker like keratin or EMA, and two, a myoepithelial marker. What does that mean? Myoepithelial markers can be of contractile type like SMA and calponin, of neural cresty type of differentiation like S100 SOX10 GFAP, or of basal differentiation, basal epithelial differentiation like P40 P63. You need one from both, one from category 1, right, and one from category 2 at least. So you usually do a panel approach. EWSR1 is rearranged in about half of malignant of myoepithelial tumors. Some of them have INI1 loss. Okay. Second is chordoma of notochordal differentiation. This is really only at the base of skull or the sacrococcygeal region. These start in the bone and then they usually come out of it. So you usually get them as soft tissue biopsies. They have these bubbly or phyziliferous cells, right, embedded in this myxoid stroma. They can be of chondroid morphology or of dedifferentiated morphology, high-grade malignant spindle cell sarcoma. They have tri-differentiation. They have keratin and EMA and S100, right? So they kind of mimic the immunoprofile of myoepitheliomas. However, they also have brachyury, which is highly specific for notochordal differentiation. These are highly infiltrative, highly aggressive. They can metastasize. Okay. Versus extraskeletal myxoid chondrosarc, kind of your diagnosis of exclusion. You don't have keratin. You may or may not have S100. You don't have any other markers. You're usually in a sort of a limb or extremity of an adult, so you're not really thinking of a chordoma, right, unless it's metastatic. But you have these sort of interconnected cells that are kind of holding each other's sort of little hands with myxoid stroma, and you have EWS or NR4A3 fusion. Usually, you will do the fusion to prove it because immunos kind of won't work. Okay. These, again, are aggressive and metastatic. All right, charts. Okay, fibrous histiocytoma, dermatofibroma, we know as most common mesenchymal tumor of skin, sessile bumps with hyperpigmentation. Overlying the tumor, you have basal hyperpigmentation with epithelial hyperplasia, infiltrative into the dermis, and trapping dermal collagen. CD34, in some cases, you can have focal expression. I don't usually use immunostains because they're not really helpful to me. Variants include cellular, epithelioid, lipidized, monster, and then the deep cellular. Versus DFSP, right, diffuse strong CD34 expression, honeycomb entrapment of fat, storiform growth, collagen PDGFB rearrangement. Variants include myxoid, pigmented, i.e. Bednar, and then we already talked about fibrosarcomatous transformation. Giant cell fibroblastoma is a variant of DFSP in kids, has the same immunoprofile and the same fusion, but has these pseudovascular spaces and these giant cells. Juvenile xanthogranuloma, these orange plaques in kids with foamy histiocytes and giant cells that are wreath-like with foamy cytoplasm going right up to the epidermis. All right, AFX versus dermal sarcoma. I am highly opinionated about this because we've seen things go very wrong. AFX is question mark. Is it a spindle cell carcinoma? Is it a spindle cell melanoma? You certainly want to rule out those things in the skin. If you can't prove it, you could think about this diagnosis. However, you have to know that it should not have any infiltration into the deep subcutis. It should have a circumscribed border at the bottom. If you do not see the bottom and you are only dealing with a shaved biopsy, you can't call it an AFX because you don't know how deep it goes, okay? So, malignant spindle cell neoplasm of dermis, essentially. If you fit all the criteria of AFX, i.e., smooth border on the bottom, these behave okay. If you do not, these are highly aggressive malignant dermal sarcomas. If they have infiltration into subcutis, necrosis, LVI, PNI, those can recur and recur and recur and metastasize. So I just treat these with caution. Okay, now we're going to move on to some rarer things that might come up. So I have no good associations for them, so we're just going to go with it. Plexiform fibrohistiocytic tumor, usually young adults in the upper extremities. You have one, spindle cells that kind of look like fibroblasts, myofibroblasts, mononuclear cells in the background with associated giant cells that kind of look like a, I don't know, maybe like a giant cell tumor all together. These occasionally are metastatic, but these happen usually in the dermis and subcutis of young patients. We already talked about the tenosynovial giant cell tumors, but because we're now in the soft tissue, we want to add on giant cell tumor of soft tissue, which kind of, again, looks like GCT of bone. Does not have the same mutation, though, so you can't use the IHC to prove it, but you can use the morphology and this sort of lobulated appearance. Other matrix-forming tumors in soft tissue, we sort of already mentioned myositis ossificans, but what it is, it's an intramuscular tumor that kind of looks like nodular fasciitis in the center, but has an ossified periphery. You can probe with USP6 and find the diagnosis. Versus extraskeletal osteosarc, super rare, has an inverted pattern. You have usually bony ossification throughout, especially in the center, and you should have malignant appearing cells. You can have soft tissue chondromas that can have these like plump chondrocytes, and usually only just recurrence rather than metastasis. All right, FHI, fibrous hamartoma of infancy, axilla and groin of young kids, again with this triphasic appearance of very sort of bland myoid cells that are spindled, these more primitive, plump, almost glomoidy cells, and then fat. Okay, hemocytotic fibrolytic pomatous tumor, myxo-inflammatory fibroblastic sarcoma. Boy, if you can get through this presentation and say all of these tumor words, you have won the prize. Okay, HFLT looks like hemorrhagic fat with spindle cells. It's neoplastic, though. It has this TGF-BR MGEA5 gene rearrangement. If you look on low power, you're like, I don't know, did this patient like bleed into their fat? Look for those spindle cells. That's a tumor. It can transform to myxo-inflammatory fibroblastic sarcoma type of tumor, which almost looks like myxofibrosarc. The only difference between myxofibrosarc and myxo-inflammatory fibroblastic sarcoma are, one, location. Usually the MIFSs are on the distal extremities and hands and feet. Usually they have a little bit more inflammatory cells in the background, and usually they have these large virucyte or Reed-Sternberg-like cells poking around in the background. Again, you have to grade them based on the French system, high, intermediate, low, and they do have the MGEA5 or BRAF rearrangements, unlike myxofibrosarc, right, which does not have any specific rearrangements, and you may see them transform from an HFLT. Phosphaturic mesenchymal tumor. What do these patients present with? Basically rickets. What does that mean? That means hyper, oh my gosh, help me. Phosphate problems, right? So hyperphosphaturia, hypophosphatemia.
Hyperphosphatemia.
Thank you. Hyperphosphatemia, hypophosphaturia. Yeah?
Low urine.
Low urine. Thank you. High blood, low urine. Because of FGF23 that's being secreted by the tumor. Once you remove the tumor, the bony problems regress. You can note this because of the matrix. The cells are nondescript. I don't know, the cells are kind of these spindly, plumpy things in this fibrous stroma. However, when you start to see this weird, right, sometimes people call it grungy or calcific or microcystic smudgy stroma, think about a phosphaturic mesenchymal tumor. It can be in soft tissue, it can be in bone, it can be in the head and neck and the extremities and the trunk, anywhere. Angiomatoid fibrous histiocytoma, usually in lymph node rich areas of young adults. Again, kind of axilla and groin. You on low power, you might think like you're looking at a lymph node because you have a lymphoid rim. However, when you look in the center of it, you'll see ectatic vascular spaces and these bland, monotonous kind of spindly cells. They sometimes stain with EMA, CD99, or Desmond, and they specifically have EWSR Krebs fusions. Here are the alternate partners. They can occasionally also metastasize. to distant visceral sites or nodes. Okay, that's it. I'm sure I missed some tumors, but high yield we've given you in an hour and 20 minutes. Questions? Okay. If you come on Saturday, I'll see you again there and I'll be faster. If not, good luck.
Is that this Saturday or next Saturday?
That's this Saturday. Thank you, hypophosphatemia. Wow, I keep going in on a blur here. It's this Saturday. I think the registration is being sent out if it hasn't already.